A very good afternoon to all the wonderful audience. We welcome you for yet another exciting session on a paradigm shift towards holistic health in women. Well, here today we are three men to talk of a very sensitive and very wonderful topic on uh, postnatal period and pelvic health. It gives me indeed an honor to introduce today's speakers. Our first speaker for today is Dr. Pothiraj Pichai. Sir is Head of Department and Professor of Community Physiotherapy at KJ Somaya College of Physiotherapy in Mumbai. Sir has more than 15 years of academic experience and has a keen interest in working with PCOD, pelvic rehabilitation, and fall prevention programs. He has also numerous publications in various journals and is a very dear friend and a very keen administrator and a good teacher. So we welcome you, sir. Our second speaker for today is Dr. Mayur Revadkar. Sir is Associate Professor in Community Physiotherapy Department at KJ Somaya College of Physiotherapy in Mumbai. Sir has more than 8 years of academic experience and currently he is a PhD scholar at Tata Institute of Social Sciences in the public health sector. He is a certified yoga teacher, a childbirth educator, and also a first aid instructor. It has been indeed a privilege to be your guide, and I'm really proud to have you over with us today, sir. So we welcome both of you. And with this, I hand it over to Dr. Pothiraj.
Thank you. Thank you, sir.
Yeah.
So once again, we thank Team Sancheti, Apurva sir, Surushri ma'am for giving us the opportunity to share our knowledge and experience with the student across state of Maharashtra and outside. It's indeed a pleasure to be part of this platform. Let me start with my session. We both will be talking about postnatal period and pelvic health, the issues which women goes through postnatally specific to the pelvic health. So the objectives that we have planned is that students should be able to list some common impairments postnatally. They should be able to plan the physiotherapy management for these impairments, describe the postnatal pelvic health issues, and describe the physiotherapy management maintaining appropriate pelvic health. These are some of the objectives. So what is postnatal period? When we talk about postnatal period, it's also called as a postpartum period. Postnatal or postpartum are the terms which are alternatively being used. Also, it's called as a puerperium period, which is the initial 4 to 6 weeks is puerperium period or 4th trimester. So it's the time after birth when maternal physiologic changes related to pregnancy return to the non-pregnant state. So it takes some time for the uterus involution to happen for the ladies to get back to the normal changes. This postnatal period can be further divided into 3 phases. That can be acute phase, which is 24 hours, subacute phase, which can be around 2 to 6 weeks, and late phase, which is 6 weeks to 6 months. Now, the issues which the lady might face will be different in the acute phase, it will be different in the subacute phase, and so in the late phase. So in acute phase, she will be in the hospitalization in acute and subacute phase, where she might have, along with the pelvic floor issues, the complaints with regards to the breathing difficulties or some secretion related issues. She might have some swelling, she might have some aches and pains. Whereas in late phase, predominantly, she has a complaints which is related to your pelvic floor related issues and which are many a time unnoticed. When we talk about pelvic floor muscles, all of us are well versed with the anatomy part of it. That we know that pelvic floor muscle is consist of predominantly your levator ani and the coccygeus muscle, which forms a hammock-like structure and it supports our organs, which is the pelvic floor organs, your bladder, your uterus, all are supported on this pelvic floor muscle. Now, what happens during pregnancy or after pregnancy? So biomechanically, there are changes which are very much evidently seen, whether it is whatever is the mode of delivery. Because of the lady being bearing the child for around 9 months, there is a continuous stretch happening on your pelvic floor muscles. And because of that continuous stretch, there is change in the length tension relationship. This length tension relationship change will ultimately lead to the weakness of pelvic floor muscles. And specifically, this is more evident in multiparas as compared to the primiparas. As you can see in this particular diagram, this shows the diagram A is talking about the normal tone of levator ani, where there is acute anorectal angle. Whereas in diagram B, where there is loss of tone of pelvic floor muscles or the levator ani specifically, the anorectal angle changes, and which leads to pelvic floor muscle dysfunction. Now, what are the different types of delivery? Can I have a little interaction? Is it possible that the students can use chat window? A little interaction. We know all the different types of deliveries. So predominantly, we have full-term normal deliveries. We have full-term normal delivery with episiotomy, and we have lower segment cesarean sections. These are the three commonest techniques which are being done. Yeah, thank you, Mahima, for your input. Now, any idea or anybody would tell me that which particular mode of delivery will have more impact on the pelvic floor muscle dysfunction? Does it vary? Does the type of delivery relates to the pelvic floor muscle dysfunction? Any input from the audience? Okay, nevertheless, I can understand that it's a Saturday afternoon lecture that all of you are attending. I will not take much time or not wait for it. Yes, thank you, Kiran, Mahima, and Simran. So what happens is, if you see, the more problem is happening during full-term normal delivery. Followed by that, it is full-term normal delivery with episiotomy, and the least problem happens during the lower segment cesarean section. As there is a natural birthing process, there is a perineal trauma that is happening, which leads to evident weakness of your pelvic floor structures. So there was a research done in one of the study where they compared the three modes of delivery, where it was seen that compared to the spontaneous vaginal delivery, cesarean delivery was associated with significantly lower hazard for urinary incontinence or overactive bladder and pelvic organ prolapse. So C-section has lower hazard. In the comparison, the operative vaginal delivery, that is episiotomy, FTND with episiotomy, was associated with higher hazard of anal incontinence and pelvic organ prolapse. So we need to keep in mind to understand the relationship of mode of delivery and the pelvic floor muscle dysfunction. The commonest impairments which are seen with regards to the pelvic floor muscle dysfunction during postnatal period are urinary incontinence, pelvic floor neuropathy, prolapse of organs, impaired sexual function, and diastasis recti. I'll come to this in more detail and understand whether diastasis recti is really related or relevant when we are talking about the pelvic floor. Urinary incontinence. Now, these are the figures which I have got is from the research that I have come across, the articles that I have come across. You will see a variations in these figures. So on an average, it is seen that 21% of the vaginal delivery would suffer from urinary incontinence and 36% with the forceps delivery. The causes can be hormonal or physical. By hormonal, I mean there is a changes in hormones, such as if we take example of relaxin hormone, which leads to ligamentous laxity or increase in the connective tissue becomes more loose. And physically, there is biomechanical changes that we discuss. All this leads to weakness of pelvic floor muscle and ultimately leading to the urinary incontinence. There is damage to fascia, ligaments, pelvic floor muscles, and nerves, supporting and controlling the bladder and urethra. All these together contribute to the incontinence. Many a times this is not noticed or not reported by the patient. So it is our utmost responsibility that we do ask patient, at least from the history, that do you suffer from any of these conditions? The next is pelvic floor neuropathy. Now, this pelvic floor neuropathy is nothing but which is common repercussion of childbirth and which is less often recognized. What happens is during the natural birthing process, there is compression and stretching of the pudendal nerve, which has a nerve root value of S2 and S4. Natural course, this do recover in approximately 2 months time period. That's why the patient may not have a significant impairment per se. But there would be few patients who would have a persistent impairment and they would come with us with the complaint of either pain, perineal pain, or they will come with incontinence or fecal incontinence. So we need to keep in mind that there can be injury to the pudendal nerve as the birthing process was happening. The risk factors for this can be your small pelvic outlet, the large fetus, fetal malposition, or any other anatomical changes that can lead to pressure on the nerve. Another impairment that we discussed was prolapsed organs. All of us know that there are different types of organ prolapse. There can be cystocele, where bladder is prolapsed, there can be uterine prolapse, or there can be a rectocele. Now, all of this vary from individual to individual. The incidence is also less. Uterine prolapse is one of the commonest thing. Many a times, this condition will be evident in the perimenopausal period or postmenopausal period, when the lady has got extreme amount of a weakness. However, if we encounter the lady at the earlier, as we say that early intervention and early diagnosis, if she's being taken care in her postnatal period and she's being given the appropriate advice to strengthen her pelvic floor muscles, we can very well prevent this condition to happen. Another impairment which is seen is impaired sexual function, also called as dyspareunia. 85% of the women experience pain while intercourse, and 22% women continue to have it beyond 1 year. This particular statistics is very important and alarming to us. All the more alarming, I feel, because in the Indian context, where women is not open about this such kind of a conditions, and they need a special care. Birthing process leads to development of the scar tissue, and that scar is one of the commonest reason for pain during the penetration. And also, this is physical reason. Also, there is a mental trauma that the lady goes through. And if there is a significant trauma during birth process, that will lead to fear in her whenever any kind of a penetration happens. And with that fear, she will have painful experience during the intercourse, and which needs to be addressed to have a healthy life for both of them, for couple. Now coming to the diastasis recti, yes. Once again, I would like to ask audience that is there any relationship of diastasis recti and the pelvic floor muscles? When we talk about diastasis recti, is the separation of your rectus muscle sheath, which is your one of the part of the core muscles as a rectus muscle sheath. When we talk about the core, is always need to understand that core is formed of different muscles. From top, we have a diaphragm. From front, we have your anterior rectus muscle and your oblique muscles. From the sideways, from posteriorly, you have erector spinae multifidus, and from down, we have a pelvic floor muscles. So all of them are very much interconnected. Okay, there was one research which showed that incidence of pelvic floor dysfunction is approximately 82.8% among patients with diastasis recti. So patients who have diastasis recti have a high incidence of pelvic floor muscle dysfunction. So it is very much related and needs to be taken care of. We have also understood that there is a dynamic balance of abdominal pelvic biomechanics. And in the long run, diastasis recti, if not corrected, becomes one of the important cause of low back pain as the years passes. Another impairment can be fecal incontinence. Fecal incontinence is that way relatively less. Approximately 2 to 6% ladies might go through this. And this is most of the time associated with if there is any anal sphincter laceration while the natural delivery, or it also happens during the episiotomy procedure. Apart from this, there can be other conditions which are again related to the pelvic health, which can be coccydynia, symphysis pubic pain, after pains. After pains is a pain which persists. It's a uterine contractions post-delivery which persists. That can be one thing, and hemorrhoids. So these all conditions affect the quality of life in the postnatal period when she is going to take care of the baby. That's why they are very important that we need to address these issues. Now, how do we go ahead with assessment of pelvic floor dysfunction? The first and foremost part when we talk about assessment becomes a history taking. Again, in the Indian context, we may not be always able to do the assessment in detail. So at least if we take the history, wherein we are able to ask specific questions that are you suffering from these conditions, and lady might say yes, then we may go and further evaluation. So history taking is at least screening the person which kind of a symptoms they are suffering from. The next is on observation. Ask the lady to be in a crook lying position with the legs slightly up, away from each other, and in that position first observe the perineal health, observe the lochia, observe the whether hygiene is maintained or not. Ask the lady to cuff. On cuffing, is there any prolapse that you are evidently seen? Is there any incontinence that has been noted? So first is observation. Ask her to contract her pelvic floor muscles as if she is controlling her urine. On that thing, try to observe whether it is exclusively a pelvic floor muscle contraction, or is she contracting her adductors? Is there is a co-contraction or of other muscles, or is there a trick movement that is happening? The next comes the palpation technique. Now, when we talk about the palpation technique, there are different ways. I would not say in my experience of women's health, per vaginal examination is to be done as a last resource. It is not something which is welcoming by the women, whether it is a female therapist, whether it is a male therapist. So keep it as a last resource. You can do keeping the hand on the perineum, especially in the postnatal period when there is already a trauma to pelvic floor muscles. Any kind of a penetration is going to be painful. Preferably avoid that. If must, can be done in the later part, that is after 2 or 3 weeks period when the puerperial time is slightly getting over. That time you may go for a per vaginal examination. Otherwise, on palpationist, you can keep the hand on the perineum and you can take the help of perfect grading scale and you can evaluate the person. Apart from that, there are different scales or outcome measures which can be of use, which gives you a quantified values to assess the pelvic floor muscle function. I would like to emphasize on one of the commonest method which all the physiotherapists do use from the undergraduate as well as the postgraduate point of view. The perfect method which all of us are much aware of. Now here I want to understand that many of the time the students during their curriculum course, they do not get the opportunity to experience doing perfect method or per vaginal examination on a lady or on a woman, because the situation is always not favorable. So am I visible to you all? Now am I visible? Can somebody just confirm if I'm visible to you all?
Yes, sir, we can see you.
Okay. Thank you, sir. Thank you for the confirmation. So what simple technique that we can do is, maybe you can just keep your index finger and thumb, approximate them like this. And imagine that I'm now inserting a finger inside and putting it, the top part of the finger, I'm resting it inside here. And then I will slightly squeeze my finger on my thumb. The kind of contraction that you feel is something similar to the vaginal contraction or the levator ani contraction. So everybody, if possible, you may try it right away, that just squeeze your index finger on the thumb, let the other finger rest inside and squeeze it. The feeling that you get, that is called as contraction of vaginal muscles or the pelvic floor muscles. Now, how do we grade it? The grading is done on the perfect method, where P stands for the power, is nothing but the strength of the muscles, which we can do it on the 6-point scale, where 0 stands for nil and 5 stands for strong. The next is endurance. So endurance is nothing but the time that lady can hold the maximum voluntary contraction. This terminology is important here. So it is a maximally contraction. Suppose when you are contracting, she is able to hold it. After 4 seconds, you felt that contraction is becoming weak. So 4 is her the time that she has holded it for maximum. So always remember, it is a maximum voluntary contraction. So you need to judge it, that is it getting weaker, then you stop at that moment. So that's the endurance thing. Then comes the repetition, that is R, that is the number of maximum voluntary contractions performed with the rest of 4 seconds. So for example, suppose MVC value for her was 6 seconds. Then you will ask her to contract for 6 seconds, relax for 4 seconds. Again contract for 6 seconds, relax for 4 seconds. And how many repetitions she can do it without the fatigue being set in, that you will check. So suppose she is able to do it 3 repetitions, then her R becomes 3. The maximum repetition is 10. And the F is nothing but your how many fast contraction, that is ability to contract, relax, ability to contract, relax. Now, once again, I'm going to the audience. Pelvic floor muscle is a which type muscle? Type 1 or type 2? Why are we having that F component also? So when we talk about pelvic floor muscles, it's predominantly a postural muscles, right? So being postural muscles is predominantly type 1 muscle contraction. But when I'm saying predominantly, there are type 2 fibers also. So there are some events or some incidents in our day-to-day life where the pelvic floor muscle will contract significantly. That is called as a type 2 contraction. When I'm sitting, standing, always the pelvic floor muscle is contracting. But apart from that, when I'm lifting, maybe that is a type 2 muscle which is coming and helping me out. So for that, the fast contraction is also required. So please remember this, the ECT is every contraction time, which is just to complete the mnemonic, but PERF are the important components of perfect method.